hello everyone, and welcome to the Digital Transformation Leadership Series. Our topic today is process pivoting due to COVID. Dr. Wes Williams, CIO of Mental Health Center for Denver, was on our meetup previously about, I think, 6 months ago, or maybe more. In one of his responses last time, he talked about some of the pivots in process he had to make. So we thought it would be great to hear from him on what those process pivots were and what technology he had to quickly adopt to support it. Maybe he had to shelve some, build some, whatever he had to do to, enable the process pivoting. Lou Strahan is our moderator and co-organizer of this meetup. He's prepared some great questions. I can't wait to hear and participate in the discussion. During the course of the discussion, if you have any questions, you're welcome to post them in the Q&A chat box. We'll try to get to them if time permits. With that, I kick this over to Lou. Lou, you're on.
Thanks, David. And of course, thanks, Wes. We certainly appreciate you willing to come back for more. And, let's jump straight in. So let's talk a little bit about the problem situation. Of course, everything was impacted by COVID, but in your world, very distinctly and abruptly, I would assume, between February and March of 2020. Maybe you could just kind of fill us in a little bit about your landscape and the problem statement that you may have incurred, say, somewhere there in early March.
Sure thing. So first of all, a little context about my role at the Mental Health Center in Denver, right? So the Mental Health Center in Denver is a private, not-for-profit healthcare provider located here in Denver, Colorado. And we have about 850 employees in 35 different locations throughout the city, providing lifespan clinical services, right? So psychiatry services and psychotherapy, but also psychosocial rehab to get people engaged with work or back at school. We have 14 different residential facilities, crisis walk-in facilities, school-based clinicians, and so on. So one of the components with that, right, is that service delivery is complicated because there's not a single one-size-fits-all solution. Right? The other piece is that at any given time, we have 13,000 people open for treatment, right? And so a disruption would have a significant impact on the health of the city, actually, right? And on March 15th of last year, our crisis management team, so that was a Sunday, our crisis management team met, and it was the day, so those of you who are outdoor enthusiasts might know, that was also the day that the ski areas all shut down, right? Due to COVID. And so we got together and our CEO sort of challenged the crisis management team to the question of like, could we pivot to all, remote service delivery, right? What would that look like and how quickly could we do it? Right? And so we took the afternoon to take a look, and really it boils down to a transformation in two different areas, right? One is for our staff, shifting from basically 100% in person to a workforce that almost entirely was telecommuting. And then two, in terms of delivering the services, going from in-person psychotherapy to telehealth, right? But I think those two components, telehealth and telecommuting, presented some different challenges, right? And then in addition, we did have to keep some of those facilities, the crisis clinics, the pharmacy, the residential facilities, they can't go virtual, right? And so we had to support those as well.
When you started out, what was the landscape? Did you have tools already in place? Did you have budget already in place? What did it look like?
Yeah, so there were two parts of that, right? There was the sort of immediate solution as well as the longer term solution that dictated sort of where we're at. In terms of the immediate piece, I had started asking the question, like, what could we do if we had to shift to telehealth, in February? And the answer that I came up with at that point was, we had been doing a very slow, very methodical rollout of Microsoft Teams, and the vision there, the roadmap was really just internal collaboration. It had nothing to do with service delivery, right? But we had rolled it out maybe over the previous 6 months or 9 months to the first 400 staff. And so we still had 450 staff to go with the Teams implementation. But we decided like this was our best bet for deploying a telehealth platform to folks really fast. And so overnight we deployed, people woke up Monday morning to learn that they had been launched onto Microsoft Teams. And, the sort of hairy part was working with a Microsoft reseller to get the audio conference licenses that would allow us to use it as a telehealth platform, right? That was the last piece to fall into play, it took probably 36 hours from deciding like I need 1,000 licenses to getting them, right? And so, that was a decision we made Sunday night, and by I think Tuesday morning we had everything in place to start rendering services. What we ended up doing on Monday was shutting down the business, right? Canceling all the appointments for that day, and staff came in and took everything out of their offices and brought it home. In general, the tech stack responded really well. Phones were the worst, right? In terms of that. That took a little longer to, because they had to be physically touched, each and every phone, right? The other part there was longer term, right? We had some budget to sort of implement an API strategy with our electronic health record. The purpose of the strategy was to move away from being dependent on our electronic health record vendor for all the solutions, and instead sort of leverage the evolving landscape of API standardization, in particular in healthcare, the fast healthcare interoperability resource, FHIR, leveraging FHIR resources to connect other solutions into our electronic health record, right? So we had a budget of maybe a $250,000 sort of already allocated in the capital budget. And we had actually been negotiating, a arrangement to, what would that first use case look like in terms of standing up to some FHIR resources. And it was based on, we should do vitals for nursing, because, the workstation is far away from the nursing station, was the idea. And we could do something more on a handheld device that would be more nurse friendly. And when the pandemic happened, we were like, okay, that's not the use case we're going to do first, right? The first use case is appointments, right? We need to publish appointments and have an app so that people can connect via telehealth and sustain it, right? Because the first month and a half, it was a little chaotic, right? And we needed something longer term that could make things work. And in particular, I think as a business, we felt like there's an opportunity here. People resist change, and yet they have to practice this. And we had seen that there were benefits to telehealth prior to the pandemic, but there wasn't much traction to do the work to figure it out, right? And as a business, we felt like, okay, well, what's the lemonade we're going to make look like, right? And that would be sustaining long-term telehealth gains post-pandemic, right? How do we give this as an option that increases access and and sort of inclusivity around bringing people into care? And part of that was making it really easy. So where do we see the obstacles to telehealth in that first 6 weeks? And how do we eliminate those obstacles? Right?
The patient experience was essentially my first day. I'm going to show up on a Microsoft Teams meeting. Hi, doc, let's talk. And one of the things that you had done the previous week were probably validating that you are who you say you are. There's identification, there's documentation, there's how do we make sure that this person is still on the same insurance? There's validation. All those process things that happen as the swan is swimming along the lake is furious paddling beneath the surface. How did you go from this is our urgent solution to getting those rocks in place to make things work?
Yeah, I wish it was as quick as 6 weeks to figure out some of those things, right? In particular, the hardest part was, the paperwork, right? And some of the emergency declaration paved the way for us to sort of take a verbal attestation, right? Say, explain to someone, here's the paperwork that we're reviewing right now, and I'll mail you a copy of it, right? And so it was a pretty old school solution, right? We would write down in the EHR, like, okay, that, this person agreed to this thing, and then we'd send them a paper copy in the mail or a digital copy. We posted digital PDFs on our website and said, like, this is where you can go get this form that you just signed. But it wasn't that tight, and frankly, not all of the rules relaxed, right? And in particular, there are important privacy rules for behavioral health around the treatment of substance use disorders. And they're there for a reason, right? Like those rules, which are part of the law 42 CFR Part 2, right? Are, say essentially that while in healthcare, the Health Information Portability and Accountability Act allows for sharing of healthcare data between providers for treatment, payment, and operations. Substance use disorder treatment data does not allow that same free exchange, right? People need to grant permission, and that permission was not relaxed during the emergency. And there was no space for just getting verbal permission, right? It had to be written. And so that was a lot of work. And people did sort of tough workarounds in the initial days. And so one of the big technology priorities was integrating DocuSign into our sort of solution stack, right? And first it was a matter of selecting the platform and getting it right. And then, and we did it in sort of evolutions. The first was just a standalone DocuSign solution, right? And then we integrated it with our electronic health record with web services. So staff could click sign by a DocuSign, right? And it would read the email stored in the EHR under the patient email field and shoot off an email to that person, right? Finally, we wrapped it inside the telehealth app that we built around the appointments, right? And so, so that it was sort of a full circuit kind of thing, right? We could send it out from the EHR, so right within staff workflow, and then it gets sent up. But using these FHIR APIs, the telehealth app that we released would show all the appointments and documents that any individual receiving services had on file, right? And they could view those documents and sign them right within the app. And so I think, and we released that in September, I think. So, you're looking at 6 months, which is both fast and slow. It's like, it's fast for a software project. It's slow for having to do workarounds that long. But that was the crucible this last year was.
Over your journey of a year now, you've got maybe some things that didn't hit the mark. What fell off the whiteboard when you're redrawing and re-innovating?
So I think one of the things that I assume your audience here is, a group of sort of fellow technologists. And I think, people can be pretty sort of literal, like, oh, there's just 10 steps. You have to follow all 10 and then it'll work every time, right? And guess what? 10 is too many, especially in a field of healthcare that is around working with people in emotional distress, right? Think about the work that we do and how, how it helps to be sort of in a calm, non-distracted sort of flow state doing that work, right? And then then put yourself in the shoes of the people that we see receiving services, right? They're not in that calm flow state, right? And so asking people to do all these different steps on their own doesn't work, right? And like having okay, here's your, we put in up help guides of, here's this PDF with like, all the steps you need to set up your computer at home to be able to receive telehealth services. And that worked for some folks, but not for everyone. And I think for the vast majority of folks, they needed time, someone really hand-holding them and walking them through. Here's how you get here. It's around sort of showing someone how to be successful doing this, and probably, thinking about really probably tripling the amount of time you might normally expect to have it work if everything works successfully, because it doesn't always work that way, right? Like there's confusion and whatever. The good news about it is, we looked into the rules and the regulations and figured out how to actually, get reimbursed for the work we did in helping people get set up with telehealth, right? I think so. That was an important sort of shift. And I think reading the landscape there, the big takeaway is like, if you find yourself spending a lot of time doing stuff that you didn't expect to do, figure out like how that gets included in part of the job.
That's an interesting journey. Essentially, your mental health practitioners went from being excellent at their job to having a part-time job of help desk to get your patients connected and comfortable and engaging. So it's hats off to you. That's a heck of a journey. We've talked quite a bit about the service delivery side and some of the technology stack there. Maybe let's talk about the people that wear your badges, the people, your staff, and some of the things that they had to overcome and they had to change the way they do work.
Yeah. So that actually was really significant. And there were a couple things I want to highlight. First of all, like the pace of change was much higher than we normally go through. And the degree of uncertainty was similarly high, right? Like and actually, we were just talking about this yesterday. Our crisis management team still meets weekly to talk about, handling COVID and what's it look like for our business. And, now with our workforce starting to get vaccinated, right? And, there's still a lot of uncertainty around that. We're having a very similar feel right now. And what I can say is we had to do some things differently in terms of communication with staff, right? Communication both around communicating things multiple times, because we know that just because everyone, like, people need it for reassurance and they don't remember, right? As well as communicating when we don't know all the answers, we just know some of them, right? And then, and so we actually adopted some structural changes that I'm really excited about around that kind of communication. The biggest ones is a couple of years ago, I read an article about the Intermountain Health System out in Utah, right? And what they were doing around communications. And they had this system of nested huddles that we adopted. So every day we do now 3 15-minute huddles, right? From 8 to 8:15 in the morning, all employees report up to their manager, right? Every day. And then from 8:20 to 8:35, right? All the managers report up to their VP, right? And then from 8:40, to 8:55, all the VPs report up to the CEO. So every day, like the question becomes in those stand-ups, what issues need to be addressed? What can be solved at this level and what needs to be escalated up a level, right? And then you'll notice, right, like, so it gets up to the VPs, and then when are we going to have time to deal with it when we're working with the CEO and there's these issues there? And so that led to the second change, which is all of the VPs are now required to have 2 blocks of time every day, right? So from 9 to 10 and from 4 to 5, we're sort of not allowed to schedule meetings, right? And instead, we sort of dedicate that as work time to deal with issues either that came up in the huddle that we agreed to, right? That's sort of what the 9 o'clock hour is for, or that arise during the day that need buttoning up before it's time to call it a day, right? And so having the discipline to, structure times like that, and the other component there was shifting meetings and meeting culture. I see this meetup follows the guidelines that we've adopted as well by going from 12 to 12:50 here and giving people 10 minutes before the next thing. That was super important, right? I think we were not alone in being exhausted in the first 6 weeks of the pandemic, sort of with our newfound powers to teleport from meeting to meeting. Even internal meetings, you had to walk across the building in the before times, right? And I spent a lot of my day driving around the city to our different locations, to locations of community partners. And I don't get a break like that anymore. And so putting in a set of rules like half-hour meetings last 25 minutes, hour-long meetings last 50 minutes. And, longer meetings, you get at least a 15-minute break before your next thing. Between that and having the discipline to not schedule things over lunch, except for in cases like my friends Lou and David here, right? Like, I have the ability to sort of recharge, and it's not exhausting. I think that, the theme there was like, this is a marathon. It's not a sprint, and you have to treat it as such, right? Treat it like this is going to be ongoing. For us, our staff, I think, as a healthcare organization, will, for the most part, all be vaccinated fully by the end of March. And that's not true of the people we serve, right? And we can't just open up our business and have the people coming in to receive care getting each other sick. So we still have to figure this stuff out, and it's going to take a long time. And I think these process pieces, but also being aware of like our capacity as leaders, like to make these decisions for the long haul and to let our staff know what's happening as best we can.
That is such a great response. I've read several articles recently of the concept of Zoom fatigue, and going throughout the day from Zoom meeting to Microsoft Team meeting to some other particular technology, and gone are the days where you could go have a brief sidebar conversation at the coffee pot, on the elevator, talking to someone as you're walking down the hall. Basically, it's on time, and when you're on, you have to be prepared for that on time. How does that, if I just have one quick glance back for your actual patients, before maybe they had some commute time, they had to get to the office, they did some things, they waited for a while. What has that changed for them with these type transformations?
Well, I think, so what's good for staff isn't necessarily good for the people we serve, right? I think for them, so we see a higher sort of appointment adherence rate here with telehealth than we did with in-person services, right? And that is particularly true for the services that are scheduled further apart, right? So in general, like treatment, like in our child and family teams, they might see someone at the same time every week, right? Or have sort of usual contact points. But to see the psychiatrist, especially once medications are stable, that's like every 2 months, maybe, right? And so people in general have a rough time committing to something like, I will be at this physical spot 8 weeks from now at this time, right? Like it's hard for people to predict what else is going to be going on in their life, right? And so historically, we've had a tough no-show rate for those far out appointments. Like I don't know, something like 15 or 20% of all those appointments. And those are appointments with our most expensive providers, right? Like in terms of the cost of the business, as well as providers that are, that there's a shortage of them in the workforce, right? So I read a statistic that for every one psychiatrist that's entering the field from residency, there are 2 who are retiring, right? So the workforce is shrinking. And yet it's a bottleneck to care. And so having that waste in the system of, people essentially having an extra 20% capacity, but not providing services during that time, like that's no good, right? But now what we find is like, so we set up a telehealth session, and if someone doesn't show right up for that, we call them, right? And that was something we would never do before, but we're getting the help to the people who need it, much more. And I think I'm not sure if the numbers settled down, but we saw sort of a 30% reduction in the show rate there. And that means that we can get help to more people.
The best way I could say it is that's a blessing. But, just from a workforce efficiency perspective, clearly those expensive resources, being optimally utilized is a benefit. From the actual patient themselves, maybe they don't have to, catch a bus and take 45 minutes to get to your office and wait another 20 minutes in the office. And, all of a sudden their time goes from the top of the hour to, the bottom of the hour, rather than a 4-hour chunk out of their day, right?
No, that's exactly right. And I think it helps support another really important part, which is that, people can get treatment and still hold down a job, right? Like you think about trying to take a half day off every week, right? Like you just can't do that from a job, right? Like, but you might be able to take half an hour off every week, right? And so in terms of access to care, I think it's been a real blessing. And I think there'll be folks who, want to keep that long term. And we want to, be able to provide that for folks. The other side of that is I think we've had to ask, well, what were our staff doing during those, during the no-shows? Like, and how do we provide tools for them to get that part of their job done more efficiently, right? There's just not sort of a, and so I think focusing on provider workflow has been really important this year, and making sure we understand like where's the waste and where do we remove obstacles so that people can focus on patient care.
Maybe we could talk to our favorite technologists out there in the audience, and maybe you could give us just a broad brush of what's going on behind the scenes. I mean, I know you mentioned Microsoft Teams. There's probably a much more robust tech stack, and it's grown and matured over the past year. Can you paint the brush with a technology stack for a few minutes and tell us what happened?
Yeah, absolutely. So, we are a Microsoft shop, right? And I understand that people might make other choices, but like for us, it's in our position, especially as a not-for-profit healthcare provider, their pricing's great, right? And so we had an investment there, and in this last year, we really doubled down on that, right? Things that we rolled out would be using Microsoft Dynamics for the CRM function. One of the things I'm proud that we did really fast and that we're still using here is, we had been using CRM for, donor management and like the sort of philanthropy strategy of the organization, managing those relationships. And yet, like, in the early days of the pandemic, we said, how can we communicate with the people we serve, right? Our patients, and we were like, the fastest thing to do is to essentially take what we had built for donor management, make a second copy of that, and clear out all the donor information and load patient data from the electronic health record into it and communicate with them that way. And it's been great. Like, we actually just sent out a blast yesterday, letting folks know about version 2.0 of our telehealth app that we built that I have sort of alluded to. And, within 24 hours, we got 80 new registrations on the app. So that's been a win in terms of communicating what's going on with the people we serve. And, the telehealth app itself has been the other big thing in terms of the tech stack, right? So the telehealth appointments are done via Teams, and the app on the back end is using all the Azure and Azure sort of tools, right? Like, I think using sort of Terraform for sort of some DevOps processes, and we use Azure APIs to sort of create FHIR endpoints. One of the tricky pieces is our EHR vendor has a sort of a mix of different API tools, right? So they have published some FHIR endpoints, which is a RESTful API, but they also have a whole set of older SOAP APIs, as well as some connections that they allow over JDBC connections, other ways, sort of ins and outs, right? And what we ended up doing is a lot of work sort of wrapping all of those sort of older APIs into a FHIR interface before plugging the app, the telehealth app that is for the people we serve, into those APIs. The rationale for that strategy is this way we can do two things with the telehealth app, right? One, we can create multiple instances of it and offer it to other healthcare providers as a product, right? They can license it, and they don't have to use the same electronic health record that way because we're connecting with standard interfaces. The other piece is we don't have to use the same electronic health record. If we either chose to migrate our entire business or even just a part of our business, a new line of business, for example, that used a more specialized electronic health record, we could make that same level of connection. The other piece that in terms of tech stack that I'm really excited about was we did the front end development in Flutter, right? So Flutter is the non-Microsoft part of this stack, right? That is, I believe, Google's software development kit, right? But one of the reasons we chose Flutter was the ability to share code across platforms, right? And so we went mobile first because we felt like that's where our patient population was in terms of device ownership. Like most folks do have smartphones these days, even folks who receive Medicaid, but we definitely needed to serve both iOS and Android, and Flutter allowed us to develop the code and easily sort of have it on both platforms. But then as things went along, we found like some people didn't want to use it, right? People had gotten laptops through the pandemic and a much higher rate than we had previously seen before. And that's where people wanted to do their telehealth appointments, right? And so version 2.0 that I was just mentioning was the sort of web client version of it, right? So now you don't need an app, you can just use it in a browser, right? And it took the team, I think it was about 7 weeks to develop the web client version. from the mobile app foundation that we had built. And I think Flutter was a big part of, essentially not having to rewrite so much of it, right? And the formatting on the app's a little different, right? The mobile app is just sort of one column. With the browser version, we used responsive design to sort of sense screen size, right? And the smaller screens are one column. More of a tablet-like view is a 2-column view, and then on a full laptop or computer, it sort of switches over to 3 columns, right? But each sort of tile or object within the app is the same on all of the different platforms, right? And I think I'm really glad that we made those choices to develop it in a way where it was going to be easy to maintain and easy to shift like that. So I think being able to deliver in, thinking about like the web app we released this month after starting the project from scratch in April, right? So I feel pretty good about that.
That's a great story of portability. I mean, the investments that you already had wrapped into new tech stack components, and then being able to look to the left and right and put that same functionality on the different platforms. That's a great story all into itself. Well, I appreciate your time so far, but I do have to ask one other key question, and that is, for all those people out here who've listened to your story, what advice do you have to maybe your peers or somebody who's looking at this from another industry? What would you offer up as a golden nugget or that olive branch to those people who are listening?
That's a good question. I think the important part that's easy to forget is sort of making sure you're asking the question, like, what do people really want, right? Like, and what do they need? And in terms of an approach, I could not recommend more learning about human-centered design, right? And how to ask those questions around, like, how might we do this differently? And, and part of that, and, on the technology side, what I see a lot in terms of traps that people fall into is being like, hey, I've got this platform, let's see what problems it can solve, right? And someone who, Monica Van Buskirk, actually, who works at Connect for Health Colorado, I think, she taught me to fall in love with the problem, not the solution, right? What are you trying to fix? Why are you building this thing? And get really deep into that and understand the nuances of what problems you're trying to solve with technology before getting too far in with the technology itself, right? Too often, I think people are like, this technology can enable so many different things, and that misses the point.
Gone are the days of feature organizers, and we actually have the experience of user experience, centralized design and concepts, particularly such as human-centered design. It's an absolute great view on our problems. And, I just want to let you know that we can't thank you enough for the great story that you've told us today.
I think there were so many insights and takeaways there, but, I think one that struck me was your takeaway on, how we measure tech adoption. A lot of it is just like, how much is my staff utilizing tech for service delivery? But your approach is more in terms of, how does it affect the realities of our life in general? I think that to me is, rightfully, we call it human-centered design, right? So it's not technology for technology's sake. More, it goes beyond that. Thank you, Lou, for facilitating a great discussion. Enjoyed all your questions there. Just to the folks that are attending, a recording of this will be available on our YouTube channel. Again, a couple of ways to get to it. You can either join our private LinkedIn group, Digital Transformation Masters, on LinkedIn or search for Mode Stack on YouTube and hit that subscribe button. Thanks again, Wes and Lou, both of you. We will see you all in our next meetup on the series. Thanks. Have a good
Sounds
day.
good.
Bye.
Guys.